Hello, everyone. Welcome to the next episode of Dr. Suit. Today, Sharon and I will be talking about a very interesting topic in healthcare pertaining towards healthcare economics and global health. We have a very interesting guest with us today, Preeti Pasricha. Preeti is a healthcare economics researcher at the Care Policy and Evaluation Center in the London School of Economics and Political Science. She uses data and economic modeling to work in the intersection of economics, policy, and healthcare. After graduating from LSE, she worked in the government and public sector, consulting in Ernst & Young as a tech consultant. In her role, she used data to really gain experience in terms of how policies are impacted in the United Kingdom. She also led a diversity, equity, and inclusion strategy in her team and founded and headed a research program in a foreign policy think tank. Eventually, she transitioned to medicine and is currently pursuing her MBBS at University of Southampton. Preeti has research interests in global health, psychiatry of refugees, migration, social prescribing, and diversity and inclusion. Using multiple research methods and economic evaluation, she recently co-authored an economic report analyzing and modeling the integration of refugees in the UK. And besides this, she also has experience in social entrepreneurship, recently receiving a scholarship from the Unleash Young Leaders program in Sustainable Development Goals, where she worked with other young talents from around the world to really develop pertaining healthcare solutions. So, hi, Preeti. Thanks for joining us today.
Thank you so much.
And how has your journey been so far? And how did you think of shifting towards medicine?
No, thank you for inviting me as well. I'm really excited for this, and that's a great question. So, in terms of just how my journey's been so far, I'd say it's been a very introspective journey. It definitely took a lot of thought and reflection to shift across like different spheres and also move into medicine. And I'd say my journey so far has really taught me how to adapt to different types of changes and be adaptable, but also learn to recognize myself in a way where I identify with the values that I align with more than the title I might have, for example. So I find a lot of the times people will ask you, like, what do you do or who are you as a title, but I think it's important to recognize your identity as something a bit beyond that in terms of the values you have. So that's something I carried forward with me into medicine as well and across my different roles. And you also asked me why I went into medicine. So a lot of it is from sort of personal experiences I've had across the course of my life. I always had that missing part of my life where I needed to work with people and make that impact on a very human level. A lot of my work before that had been on more of a policy or government level more than a human level. And a lot of the experiences I'd had outside of my formal work were volunteering in sort of community health settings, which I wanted to bring into my professional life as well.
Oh, that's actually wonderful. So you realize that although you were making significant impact at a very government level in some way or the other, you realize that true interaction with humans was your calling for medicine, if I'm not mistaken.
Yeah, essentially.
That is so wonderful because we just had a conversation with somebody and we were talking about it from the other end of the spectrum where we were talking about physicians being involved with their patients, but then it's our responsibility to kind of being involved with the larger public health spectrum as well.
No, I think that's a really important point as well, because I think you can only make those policy decisions and ideas on a macro level when you've had that experience on a micro level as well.
That's very interesting. To really understand this exciting career path from tech consulting to health economics and now medicine. So, what does the intersection of policy, economics, and healthcare exactly look like from your perspective while you're pursuing your medicine career?
The intersection of healthcare, economics, and also policy is very you can't untangle those three things, especially when you're making decisions that can affect healthcare. Fortunately or unfortunately, that's another conversation, very much linked to economics. A lot of the issues that we have in healthcare are economic related, where there's an issue of resource allocation, for example. Either how does the doctor decide which patient should receive what quantity of treatment because they have a limited resource in their hands on the wards, versus someone making a policy decision, which is also a very limited number of resources and you have to identify how to allocate them. So I think In my perspective and from my experience, the intersection really comes in when you're trying to understand how do you really allocate very limited resources in a fair and equitable way to maximize the output, whether that's on a ward as a doctor or you're managing the hospital, whether that's privately or publicly, or even on a government level when you're making policy. It's very hard to do that if you don't actually understand where those resources should be most allocated.
I never thought about the perspective of resource allocation. Sharon, what are your viewpoints on this specifically?
Yeah, I was kind of thinking about this, and I think you hit the nail on the head, which is resource allocation is extremely important, of course, but then being formally trained in economics and having seen the big picture, and then as you said, it's the same principles at play in the big picture and on the wards. But then because you have the big picture in mind, you understand what you're doing on the wards. And in the same vein, because you're on the wards, you understand what are the changes needed in the big picture on the back end as well.
That, in my opinion, is sometimes missing in healthcare policy as well, especially if healthcare policy decisions are made by people who have not actually had experience working in healthcare themselves. Where, exactly like what you just said, if you don't understand what's on the ward, then you won't understand where to actually do it from a higher level.
So, to really understand what is exactly health economics, since we haven't been exposed to this term, both at a micro level and macro level, and how both of them are interconnected. If you can just shed some perspectives towards that.
Sure. So if I understand, essentially try and define health economics, but in this context. So in my perspective, health economics essentially finds the limited resources, which could be financial, but they could also be other types of resources, such as land or labor as well, and tries to allocate them in such a way that really maximizes the output. And output could be measured by many things. It could be a financial output. It could also be general utility. It could be patient welfare. It could be any kind of output, but maximize that kind of output with the limited inputs that we've got. So, for example, there's also organizations that will do that on a global level. So the World Health Organization or the Global Fund or the World Bank might look at designing healthcare systems in such a way that allocates these limited resources more on a financial level at the more macro side. And a doctor would also do the exact same thing, but using their limited resources in terms of their labor, for example. And I find it quite interesting because I think it varies quite a lot depending on the type of resource setting that you have as well. So in a lower resource setting, for example, I find that a lot of the limits in resource can be more financial rather than labor related, where you might have many trained doctors, but they just don't have the actual resources to provide the care that they are capable of doing. Whereas in a higher resource setting, that could look very different as well. It might be that you have labor and capital, but you might have a different type of resource that's not available to deliver the care.
So if I had to tell anyone about economics, I could probably say minimum resources, maximum output, or could I say efficiency?
ROI, I think that's the right word, like return on investment, like maximizing the ROI of your input, like maximizing the return on investment of whatever you're putting in, whatever kind of resource you're putting in, and really trying to find those levers where you can, where you're investing whatever it is you're investing, but you're maximizing the output from the other end, whether it's in a resource limited setting where the input is different, or whether it's a resource heavy setting where the input again is different, but the output is also, the desired output is going to be different.
Okay.
Right? So moving on to the next question. Again, this might seem a little repetitive, but can you help us understand your perspective on medicine as someone coming from an economic background? And I know we spoke a little bit about this, but just in general, an example would suffice where you think your perspective is somehow different from your peers on medicine because of your training.
No, I think that's a really interesting question. And I think that is also something I've thought a lot about during my training so far in medicine, where a lot of my peers have come from backgrounds where they've mostly only worked in a healthcare setting before. But I've come in working in the corporate world and in an economic setting. So I think that offers a different perspective of, I notice a lot of my context is in the National Health Services in the UK. So I notice a lot of the inefficiencies, for example, in the NHS, where I worked in technology consulting and I'm not used to having to deal with manual paper on the wards, for example. So the lack of technology and more efficient ways of delivering care directly to the patient is one thing that I've noticed that potentially someone who's only ever been in healthcare might not pick up on, or necessarily have a different experience of using outside of the healthcare setting. Another thing that I notice is I also notice the policy side of things as well when I'm in medicine. So as well as understanding the more biological side of medicine and on a patient to doctor level, how you directly speak to them, I can also notice that that is directly impacted by the policy decisions that were made on an economic level from the government, that doctors can be, in many healthcare settings, not just the UK, very stretched, oftentimes underpaid as well, depending on the country that they're in. Sometimes also they're working with very limited resources and making decisions on how long they can keep someone on a bed on the wards, because that bed is very limited and there are not enough to go around for every patient. And that's directly related to funding given to the NHS, which is again a health economics question. So those kind of things, I draw the connections between when I'm also thinking about things on the ward too.
I don't think we've ever thought about healthcare like that, but I think now let me flip that question and kind of ask you about the other end of that spectrum, which is, although I understand you're in the early phases of your medical training, but has whatever experience you have in medicine, has that changed the way you think about spreadsheets and economics?
That's a really good question. And I'd say so, yeah. So I think in sort of two ways it's changed how I see the sort of spreadsheets economic side of thing. One is I already had a bit of healthcare economics experience before I entered my medical training, and being in medicine has then allowed me to understand to a greater extent what the main priorities are within healthcare. I think without having that medical training, I didn't understand as deeply what the actual priorities are from the other perspective. And I think not just understanding priorities in terms of where I'm directly seeing the need for more resource allocation, but it also changes your perspective in terms of you see the most vulnerable side of humanity. And in that sense, on a much more deeper level, it also makes you appreciate what's actually important more than some of the policy decisions that are made, but making healthcare very political when it's actually a very human thing as well. And I think that's sometimes forgotten when policymakers are having these conversations.
So, according to you, what are they missing exactly, the policymakers? When it comes to resource allocation, so we are gaining multiple perspectives. Let's take India and the UK. They have very similar healthcare systems. What is the issue with resource allocation that people are not able to address itself? And where does the issue come in terms of economically and also medically?
So if I understand where the issue is with resource allocation in those contexts. So that's a really great question. And I think we'll start with the UK because that's the context I understand best. A main issue in my perspective is how politicized resource allocation has become with the NHS, where sometimes it's very linked to the politics that's going on. And again, like what I was mentioning about, it's also a very human thing. And I think if people who haven't had the experience of actually yeah, like exactly, like on the wards working with humans don't necessarily see the more human side of it and can politicize it based on elections or whatever else is going on. So I think that, in my opinion, is a big issue with resource allocation. And I think also that means that there's not necessarily an understanding of what the issues are that should be addressed. So if hospitals are not in a fit condition to actually treat patients because there's leaks or there's not enough beds to go around, then that would be a priority on the wards, but that might not be the first thing to think about if you're deciding where to allocate resources. So I think in that sense, there's also a mismatch of resource allocation where the priority areas of need are not being addressed. And I haven't got enough experience of the Indian system to make a.
That's why both are very, the way the healthcare system is structured in terms of on the government level, it's very similar. Definitely, there are many private players in India compared to the UK. I'm just thinking what could be done in terms to improve, from a doctor's point of view, to improve resource allocation, because we can't change the politics, but we can change what we can do.
I feel like it's just educating physicians on basic economics and like trying to understand that, okay, for example, let's say there's a test, something like, I think, calcium scoring in coronary CTs with calcium scoring, right? Like that's a great test, but what's the ROI of that test? Right? Like there's a healthcare cost associated with it, and then what's the return on investment for that? And is it worth ordering for every single patient? And who's paying that bill? Is it the public? Is it the private? Is the patient paying out of their pocket? Is it the public? Like understanding these things on the systemic scale, I think that might be a good starting point to kind of improve resource allocation amongst physicians.
Yeah, correct. I strongly think
Yeah.
that could be a potential way. What is your thoughts, Preeti, on this?
I think that's a really great idea. And I think if physicians as well have more training in evidence-based medicine as well, I think that can be help make decisions on if we do have a limited number of resources, which is the case in many healthcare systems, how then do you know which tests are the most valuable to order, or which treatments might actually have evidence that they work, but might not necessarily be the first one that you think of. And perhaps there's also more ways to focus on prevention as well, rather than treatment, if there's more ways as well to empower patients to take more charge of their health and prevent things either getting worse or happening in the first place. Even I think primary prevention as well, or secondary prevention, looking at different screening, for example, could be a way to actually just reduce the burden in the long term. It might require a larger sunk cost to start with to actually conduct screening, but preventing it in the long term could also be an effective way.
That's very wonderfully put forward.
I think
So
I have a very small question before we move ahead,
Of
and
course.
you can give a short answer, and you can say no comments, and it's completely fine. But considering you're sitting in the UK right now, how has Brexit affected the NHS? Again, you can skip the answer if you want, but this is just something that I'm curious about.
I think the main effect that I could see was more on Labour, the Labour force within the NHS, where there were discussions afterwards around who has the right to work there, where will we employ a lot of NHS staff, which are from many countries and not just the UK. So that was one question that came up quite a lot afterwards. But I think the exact effects of Brexit are difficult to measure because it also coincided with COVID straight after. So
yeah,
what by the time Brexit had been processed and we're actually seeing effects, it was also COVID not long after. So I think that made it very hard to isolate the Brexit effects.
Nice.
Yeah.
correct. Also, Preeti, you have had significant experience towards global health itself in terms of research as well. So, according to you, what are the gaps do you often see in global health, and how can we individuals actually start thinking towards it?
By gaps in global health, do you mean gaps in sort of researching in global health, or
Well, by gaps, I mean significantly disparities, healthcare disparities towards global health.
hmm. So no, I think that's a really great question, and kind of like what we were discussing earlier with resource allocation, I think that's a big gap in global health where there's an inequitable distribution of resources between higher resource settings such as the UK and lower resource settings where they don't necessarily have access to financial resources or the correct types of infrastructure, for example, to actually deliver healthcare. And I think there's also a limited level of research in certain health settings where there might not even be data out there to even know that there's an area of priority that needs to be addressed because there's just not been any research done for it. So I think that's actually a place where health economics could come in. And I think as well on a global health scale.
But I think let's shift gears a little bit. Let's move to something that I think you're really comfortable with, which is refugee crisis, I guess. And so, like with over 100 million people displaced globally, what are the healthcare challenges refugees face? How do these challenges impact both the health outcomes and the economics of the host countries?
That's a really great question. And I think it's one that's also been less touched upon in evidence and in research and also in policy, but it's actually a very important question because refugees face very complex and unique challenges that perhaps other members of the population don't necessarily face. So one, for example, that is quite important in my opinion is the mental health conditions of refugees. They go through very complex types of trauma and PTSD, very unique types of anxieties as well that they face leaving their home countries behind, starting their life in a new country, often in very unplanned ways. So economic migrants, for example, might have a bit more of an idea of why they're going to a new country and what they intend to do there. But if you're fleeing a country because of any serious reason, whether that's war or conflict or climate change or whatever the reason for becoming a refugee is, you don't necessarily have a forward plan for what you're going to do. Exactly.
Yeah.
When you reach your new country. So as well as the anxiety of leaving your whole life behind, your occupation, your family, your friends, everything you know, you'll then got an anxiety of what are you going to do now you've reached this new country, in addition to all of the complex traumas that refugees face, which could be anything from the war and fighting and death that they've experienced along the way to losing loved ones to some quite serious assaults that can happen as well, plus dealing with a system that's very much designed to harm them as well in many ways, because getting asylum status can be a very long and arduous process in itself. So that in itself adds to the trauma. So in answer to that first question, I think a major healthcare challenge that refugees face is in their mental health. And that's not necessarily the same type of mental health issues that the general population will face.
They will have different mental health issues compared to the general population, which has not been considered. Even I was reading a statistics. In fact, I quote from a paper. Yeah. The UK has spent more than £3 billion on refugee crisis, and this leads to long asylum wait times, increase in healthcare and employment challenges. From your perspective, what policy changes need to really be created or introduced to really streamline the asylum process and improve these outcomes?
So thank you for asking that question, because I think that's a really important one, especially when it is such a large sum of money, and that in itself has so many problems as well to be spending. So I think a major policy change that needs to be made is to, correctly, as you said, reduce that waiting time on the asylum process, because the largest cost in the asylum system is accommodation costs. And when someone arrives as an asylum seeker to the country, they're also entitled to staying in a form of accommodation, which could be a detention center, it could be a barge, it could be a hotel, it could be another type of asylum accommodation. And that has a cost to it, of course. And that ends up being the largest cost. So the longer that someone spends in the asylum system, the larger the accommodation costs become. So a key priority would then be reduce the asylum waiting times and the golden question is then how do we do that? So one thing that the government has started to do is to hire more asylum caseworkers. So they will essentially try to tackle the big backlog that the UK has right now of people who are waiting in the asylum system to receive a decision on their application, as well as the new people who are coming in. And then that should, in theory, reduce the backlog. But there's also a few more deeper issues there. So one is there's a high turnover of asylum staff. So there's an issue to actually maintain morale of staff so that they keep working there and actually work in a very productive way. And there's also some inefficiencies. So one inefficiency I came across when I was researching was that there wasn't the right technology in place as well to actually process all of the applications. So those are just some things that could be done.
Can I just dive in and ask you, like, can you quantify what that waiting time looks like? So let's say I'm an immigrant and I'm a refugee, I've come to the UK to seek asylum. What is my expected wait time? Like how long do I need to wait before I'm expected to be granted asylum?
No, of course, and I think that's a really important question too, because the wait time currently is somewhere between 12 and 18 months. So you can imagine it's quite a significant amount of time for someone to arrive in a country and just not know what's going on.
And what do you think actually caused these waiting times? Is it because of documentation? Is it because of background screening? Why is the waiting time very long?
So one of the reasons why the waiting time is so long is because the asylum system managed to create a very long backlog. So it ended up meaning there were previous applications that had not been processed and then just built up and built up, as well as the fact that there were just not enough staff to actually process it in the first place. And I imagine political questions also came in on what criteria do we let someone become an asylum seeker and have refugee status.
That's pretty difficult. And when it comes to challenges of integrating them into the economic system, so a refugee has received his asylum. Now, what are the barriers that a refugee faces when integrating towards employment, healthcare, or other aspects of the society?
And I think that's a key question as well that we looked at in the paper I worked on. So key barriers to integration cover a few different areas. So you rightly mentioned employment, and that's a key method to become integrated. But the key barriers that I find are often because of health conditions, where having, for example, serious mental health issues can then become a barrier in itself to integration, because with health conditions, you then can't find employment as easily, for example. The long asylum waiting times have also been shown to be a massive barrier to integration, because firstly, you're out of employment for 12 to 18 months when you arrive in the country, but you've also got the burden of being and sitting in the asylum system for so long that you're then just not integrating in society because you're not interacting with anyone outside of the center that you're staying in. You're in quite a traumatic situation where you're sat in uncertainty for so long. And there's also other barriers as well. So the asylum waiting time and mental health conditions can also mean refugees can't then socially integrate with other people. There's also issues in certain societies of xenophobia, where it's sometimes difficult to interact with the host society if you feel unwelcomed in that society. And another major barrier that I found in the paper is also with language. So if someone comes from a country where they don't necessarily speak the same language of the host country, whichever country that is, that can also be a massive barrier to integration, where it then prevents that individual to find a job, to interact with anyone from the host country, to get further education as well. So that also becomes a massive barrier.
That's actually a very unique perspective that you bring, because integrating into society is the most essential component of driving economical growth. So when a refugee lands, technically the government pays for the refugee in terms of accommodation, asylum, and cost is borne by the country itself. But it is very important for the government to also facilitate easy integration for the refugee to the society, so they can get the return on investment later on.
like in terms of taxes that the refugee
Access and
might
all.
pay
Yeah.
going ahead. But it's kind of funny, isn't it? Because like you're spending so much money on refugees, and I understand there's like a moral responsibility of rich countries to kind of take that, sort of be on the front foot when it comes to these things. And I understand that. But then I can clearly see why like there be political issues coming up, because I would imagine the less well-off section of whatever the host country would kind of want the government to prioritize them over the incoming refugees. What is your thought on that, Preeti?
I think that's a really fascinating question, especially because it is so politically weighty, exactly like you said,
Yeah,
where it's very like easy to understand why it's such a difficult question, because integrating refugees does cost money. Research that I've done, we actually found that if the government provides tailored healthcare support as well as language support to like English language classes in the UK to actually learn the language of the host country, as well as support to find employment. So that could, for example, look like interview support or CV support or some kind of employment support to actually get the refugee into employment, and also reduce the asylum waiting times. These things would require an initial economic cost to deliver these objectives, but it would also bring a £1 billion, more than a £1 billion revenue to the UK economy over the period of 5 years. So it
but
would require,
we just
yeah.
discussed that it costs about 3 billion a year for the processing and all of that, and then you're saying it'll add up to a cost of 1 billion over 5 years. So we're talking like, if I'm not wrong, we're talking 15 versus 1 over 5 years. And I'm sure there are like a lot of nuances here, but I'm trying to kind of quantify things, because
Mm.
there is there is a huge cost to this, and I feel like there is a huge responsibility on the countries also, but we also need to understand that there's a cost to all of this.
But countering your point, Sharon, I think so. The cost is what Preeti pointed out earlier was due to the inefficiencies, if I'm not wrong,
Yeah.
rather than the cost.
Right.
And the £1 billion is also after accounting for the cost. So that would be the net
Oh,
benefit. But that would be the net benefit over 5 years.
I think that should be the pitch to like, we should look at startup founders and start pitching them that, look, you can solve this, and you can solve this, and this is the market.
It's definitely
And
very compelling when you put the numbers together. And
yeah,
when me and my colleagues did that research, we were very surprised by the actual benefit that could be like received from actually integrating refugees into society, because oftentimes in the media we hear the exact opposite, that
exactly.
it's a drain on resources, that more people are coming to the country and they're using up NHS resources or whatever the political lines are in the media. So finding that figure was a very
Pretty
nice
important.
surprise as well to see.
Yeah, because you're taking the politics out of it, right? You're taking the
Mm.
emotion and the politics out of it, and laying it as cleanly and as close to the truth as possible. But look, this is just numbers, and do with that information what you will. Moving things along, I think there's another concept of like the global north and the global south that's being talked about, especially in the media right now. And do you see any glaring changes or any glaring differences between the global north and global south when it comes to refugee integration, especially on the healthcare side? And are there any challenge? Is there anything that we can learn from each other?
Mm. I think that is a very important question, especially because we don't always hear it in the media, but many countries in the global south are actually hosting refugees.
Exactly.
And it's a significant number of refugees, as I'm so sure you would have seen as well in your research. So I think there are differences in how the global north and south actually integrate refugees, and also what resources they have to even host refugees. The main thing with the global south, just from the experiences I've heard from people I know and from what I've researched, is that there's a massive lack of resources to actually provide adequate healthcare.
Yeah.
And although we often hear in resource-rich settings, like for example in the UK, that there is overburdened healthcare systems, I find that that is even worse in the global south, where sometimes healthcare systems are even more stretched, and that can mean that for refugees it's even harder to actually get the healthcare that they need. The main difference that I also have seen is the type of accommodation that a refugee will live in. So in the global north, you're more likely to find yourself in a hotel style accommodation or a barge or a detention center or another kind of accommodation. And then once you become a refugee, that could then be a different altogether, because those are mostly pre-getting refugee status. Whereas in the global south, it's more likely that that refugee will end up in a camp, for example. And and although they're meant to be temporary, that can last for years and decades even, with very poor living conditions, often not even recognized in the system because there's no data or research on who's living in that camp. So you end up in a way becoming almost invisible to society, whereas in countries such as the global north, your entry into that country is going to be recorded, so at least you're acknowledged in society. So that's also a massive difference. And also camp-based living comes with many more complexities, such as higher rates of disease and like lack of healthcare access, etc.
That's actually a very massive problem. I mean, towards the global south. And I don't know what is being done to address these problems. I know there are organizations like UN, WHO, but what is exactly being done to integrate them into the global south itself? And
I'm sure there's
I do,
some.
yeah,
I'm sure there are like NGOs or initiatives running, but like I think you're right, Mohit. I'm sure there's a lot more that needs to be done that is being done, and I guess if we can kind of somehow contribute to this process, maybe even by just
yeah.
having a conversation about it.
From an entrepreneurial perspective, what are the emerging opportunities you actually see for improving conditions for these refugees? Any cost effective solutions that really align with how we can cater to them? Because I do remember that you went to Unleash, which is a social entrepreneurship program as well. So you would have a better perspective towards this.
On that program, that was exactly the question that we addressed, which was, what are the opportunities here when we have these very clear issues? How do we actually address them, but also in an entrepreneurial way? So perhaps to answer that question, I could talk about the project that I worked there with my team. So within my team, I worked with two people who were also doctors, but from refugee settings as well, and also two other medics there as well. And we looked at the Mahama refugee camp in Rwanda, which has got more than 50,000 Burundian refugees there. So Burundi is right next to Rwanda. It's one of the easiest countries to then enter into because of its geographical proximity. But what we found was that a lot of the refugees there, in fact, pretty much all of them in the Mahama camp, were not receiving the care that they required. So they had very specific needs. For example, they've gone through some very harrowing war experiences. They have a particular demographic. They've also got their cultural context, the language that they speak. And that's a significant number as well. 50,000 plus refugees is massive. And they're all living in a camp for many years on end. And there's just no clear end date to when they will actually be able to leave and start a life. So we asked the question of what is the main need in the camp, and then how do we address it? So in the team I was working in, we had someone who's actually from Burundi and had contacts to then ask people within the camp what is the main issue that they're facing, and we found that a key issue is their mental health needs. And a big issue then is that there's only 3 Burundian psychiatrists for the whole population of the country, so which is wild. And that's not enough for even just the camp, let alone the whole country. So we were trying to understand, okay, so there's no mental health professionals in the camp and there's only 3 in the whole country. What can we do to address mental health here? So one suggestion that we looked at is there a way to use telemedicine to then connect people who are psychiatrists or other associated mental health professionals to the camp in a way to deliver, if you can't go physically, remotely, mental health care to people who desperately need it? And that could then be the basis of an idea to an entrepreneurial idea, and that same model could then be applied to many different contexts.
That's amazing. 3 for the whole country. That's, I mean, Mohit, should we do psychiatry? Like, should we just move, change our specialties and then start doing
Like that, we should do 8 fellowships in a row. We should spend 16 years more training.
Oh my God.
That's actually horrible. Now, when it comes to social entrepreneurship as a whole, you identify the need that mental health is the issue. I want to build a telemedicine platform and I want to integrate it into society. Now it comes to the end consumer, who is the Burundian refugee. He doesn't have any economical means to pay. So then how do you monetize that aspect? Is it
I guess you get the government to fund it. We have the service. We just need somebody to pay for it. I guess that would be a... Go on. I'm sorry.
So I think there's a couple of ways to get funding for this kind of model, and you rightly said you can't ask the patient in this situation to pay for this, which would raise ethical questions, but also they just don't have the resource. So two potential ways to get funding is, as you mentioned, so through sponsorship, either government or NGO or another kind of charity organization, even private donors to sponsor this. And that could be a way to make it, assuming you have enough sponsorship over a long period of time, make it a sustainable model. Another potential way, which again is discussable depending on who you actually connect as psychiatrists, is perhaps the healthcare professional could pay a fee to sign up to the system to then be connected, which would of course be dependent on the incentive, because they are also volunteering their time to provide the care. But that could be a potential source of funding. But I think the more sustainable and easier to is through sponsorship.
Yeah.
But is that enough sponsorship available to really fund this whole journey of creating impact in society?
I think, like we've discussed before, like I think it's never, you never get to that scale in the beginning, right? You always have like a pilot project, show evidence that, hey, look, with this amount of money, we did this much. We created so XYZ impact with the little money that we did have. So if you pay us more, we can probably scale logarithmically and like get more and more and more people the help that they need. And I think like that's a way of like kind of designing, I guess, a funding program, rather than saying we need like whatever X amount of money for the whole country. I don't think anybody's going to pay for like an entire country to be. So I think, I mean, I'm sure we can keep talking. There's like a million questions in my head. Mohit, if you have any other specific questions.
Yes, I do have. So Preeti, so I do understand the term social entrepreneurship, but what is exactly it is? I mean, I know there's a word existing called social entrepreneurship. If a person is creating impact at a grassroots level, that is.
Mohit is asking, how does Mohit Mirchandani become a social entrepreneur? That is the question.
Well, yeah, that's the whole question.
Yeah, that is the question that is being asked.
I know from what I understand, it's creating grassroots level profitability. I mean, grassroots level impact. But how does that translate to profitability in the long run? Grassroots level impact and the profitability associated with it.
So I think once you've demonstrated the grassroots impact, as also you mentioned, where you kind of start from a lower level, you can then generate that profitability through building a reputation that you have generated good impact over time. There's a lot of philanthropist like funds as well, which I think can also then become a sort of self-perpetuating revenue as well, if you then build it as a business model. But as long as the goal is always there to have that social impact, I think that would also class under social entrepreneurship.
Actually, this was a wonderful session I had with you, and it gave us so many perspectives towards multiple aspects of the underserved part of the population. This is what I term it as patient advocacy.
So you're talking about patient advocacy.
And we really appreciate that you took your time to actually join us and give us your insights towards these aspects. And thank you so much for being here.
Any closing remarks you have before we?
Any closing remarks? I think I can talk a bit to maybe change and like career changing, and maybe I think the main closing remark I'd say is to, if someone is looking at, as we talked about at the start, either moving from medicine to something non-clinical or vice versa, as I did from non-clinical to clinical, is to reframe that in their mind as, instead of a career change, look at it as a career addition. And I think that would be something to maybe take away, where you're not necessarily losing what you've got before, and you're not starting from scratch when you take on a new challenge, but you're actually adding to your already very diverse and valuable set of skills, and then use that in a way to make an impact cross-discipline. That would be my closing remark.
I love that.
How difficult was it for you to actually do a career addition?
I'd say there were difficult times during that process. I surrounded myself with people who really believed in me when I was going through that change, and maintained as far as possible my conviction as well for why I made those changes, and that helped it make it a much easier journey as well.
I think we need to wrap up, otherwise we're going to keep talking. So thank you, Preeti, for coming on the
Thank you
show.
so much.
Mohit, any closing remarks you have?
Whenever we are talking about medicine, it's very essential to also talk about the economics aspects of medicine, right? Resources put in, and it's also necessary to understand what population level we are dealing with: underserved, overserved, mediocre, and really try to allocate your resources accordingly. That's about it.
Right. Thank you so much, Preeti, for joining us.
Thank you. It's been a pleasure.